Hello, and welcome to another episode of the Med School Minutes podcast, where we discuss what it takes to attend and successfully complete a medical program. This show is brought to you by St. James School of Medicine. Here is your host, Kaushik Gua.
You know, obviously there's a lot of paperwork happening and getting you all the way up to orientation. What's residency like? Finally, we get to the question. What is...
Oh, we were waiting for this the whole time.
What is residency like?
Yeah.
So, first question is, you know, obviously you were a counselor here. I've seen you. I knew what kind of a program you wanted. And you had certain expectations about residency, about being a doctor. Is residency the first couple of months? Obviously, you've been been there less than a year. Has it been number one? Has this program or getting into residency, has it been uplifting or stressful? Number two is what you had in your mind when you were applying for residency and in med school? Is your residency like that? Or is it much worse? Or is it far more tedious? Or is it just you're not seeing that many patients, you're spending much more time doing paperwork? Or I don't know. Did it meet your expectations that you had when you were in med school? Is residency a lot harder than what you expected it to be? Can you kind of walk us through what that experience was and
Absolutely.
what you think?
So, now that we got through the paperwork and got out of it, and I'll tell you, residency itself, it's a lot more smoother in terms of what is required of you, what is needed to be done, and you have your schedules. Obviously, you have your call schedule. You have your for me, I have also a clinic schedule sometimes because I have to see my clinic patients, and I have my inpatient services and my rotation hours and everything. So it's all laid out. You know exactly what you're doing and where you're going to be starting on day one. So for me, when I first started on my day one, I was starting on a rotation called Bravo. And Bravo is basically an inpatient service for women and children. So, and majority of the women, what I mean by that is pregnancy, women in their pregnancy. Not women as in maybe a 30-year-old woman who may come into the hospital for a complaint. Not that individual who is pregnant and then comes with a complaint, and they will be in that. So that's what I had to kind of work with in my first rotation, which roughly lasted approximately 4 weeks. Each rotation lasts 4 weeks. And so when I came on my first day, the craziest part about my rotation was that there was no senior with me. It was just me. So I came into the rotation. It's just me. I got a, I think it was like a day before July 1st. I got a rundown, a sign out from the previous resident telling me who the patients are, what was the planning that had been done, and then all the information and moving forward is basically a sign out for me. Once I got that sign out, the following morning, I had to be at the hospital at approximately around by 6 a.m. I had to be in the hospital. And at 6 a.m., I got a little bit of rundown from the night float individual, what they told me if anything happened with my patients. Once that was finished, I had to go see my patients in the because there's two hospitals, the Women and Children Hospital and then your main hospital. I had to go right over, walk across, do my rounding on all the patients, and then come back and then wait for the attending, then to go with them and present them my patient and tell them what my plan was. So on the first day, lucky for me, a lot of my patients were stable. So I didn't really have, crazy things to handle or deal with. Only thing that I kind of handled and dealt with were, writing the note, being able to update on what the patient was going through that day, anything that changed, and then that's about it. And majority of the management was kind of already laid out and done. So that was my first kind of day. It was a lot simpler and easier than I had thought. So I was kind of glad about that. But then as the week go ahead.
Side question on that. Did you have what you call quote unquote imposter syndrome that day? Or were you like, I totally got this. St. James just knocked it out of the park for me. So Or because I've heard this from even students who were from like, top tier US schools are like, residency first day, I had no idea. Did you feel the same way?
I definitely felt I was definitely nervous. Okay.
Okay.
But the craziest thing was our program and the faculty honed in on us that, hey, wherever you go, it's no longer, hey, my name is Saad Hanan. No, it's got to be, I'm Dr. Hanan, and you got to be you have to be able to say, you can't, you don't want anyone calling you by your first name. And they honed in on us, and they're like, you can make friends with people and they can have you on a first name basis, but in the hospital and wherever you are, you have to be very professional. You say, hey, my name is Dr. Hanan. So it was kind of weird for me, because even sometimes I would go up in my first day, and my normal response is when I speak to somebody like, hey, my name is Saad, I had to switch really. So I sometimes would stutter and I'd be like, hey, my name is Dr. Hanan. I'm here to check in on this patient.
Okay.
Do you have any updates for me from last night? And the nurses will tell you this or that, and then you get the information. And even when you go speak with patients, again, I would sometimes stutter because I'm like, oh, I'm like, it's so automatic for me throughout my life. I've been just saying my name is Saad, that now it's like a whole different thing. And I have to be like, hey, my name is Dr. Hanan. I'm taking over, your service for today. This is what I'm going to be doing. This is what the plan is. My attending will be here afterwards. So the first day was definitely a bit interesting. Have I had that imposter syndrome feeling? Kind of. There were times where I felt like maybe I'm not up to par. Should I be doing more, or am I not doing enough, or am I doing maybe too much, or what am I doing? Like if I'm doing everything right. And I think the best part about that is that it forces you to, on a continuous basis, to learn. So even if the patient is completely stable, you're walking through the hall as you're getting to the patient. You open up your UpToDate app or one of your bedside medicine apps, and you start to say, okay, what is the stability, and how long should these medications be on, and what is the proper dosage for this child with this weight? And so you're doing all of that as you're walking over, and you're like, oh my God, I know some of it, but I don't know a lot of this other stuff, because that stuff you don't really get to learn in medical school, because that is now practice, right? You don't learn like, oh, what dosage do I need for this exact patient and their weight, or how long does this person need to be on medication, or when do I de-escalate that medication and go and transfer to a different antibiotic. Those are things you learn in practice. And so obviously in the beginning, you're going to be confused. You're not sure. But if you have a general grasp, you're not going to be out of the conversation. And that's the whole goal. You need to your foundation need to be there so you can be part of the conversation. And there will be times where you have no idea why certain medication is going for that long in the beginning, but it'll be something you'll pick up on and you'll learn as you go through it. So yes, on my first day, I was very nervous. Entering rooms, I was very nervous. Speaking to patients, I was very nervous. But the thing is that I've had patient interactions before. In rotations, I've spoken with patients. I've done my externships, and over there I've spoken with patients. But the difference here is there's no attending, or there's no preceptor I look over and say, that's my plan, what do you think? This is me and the patient actually asking me, like, what do you think? And I'm the one who has to now make that judgment call. I have to be the one to say, okay, well, I think we need to start with this medication. Now, obviously, I will run it by my attending, but the onus of it comes on to you. You're the one making that call. You're the one who's going to be like, okay, this is what I want to do. And the attending will be like, I don't think that's a good idea at all. Or yes, that's a good idea. But there's nobody else you can go to and ask, or be like, oh, I have this patient with these symptoms, and this all of a sudden happened. And what do you think? The attending was like, you're the doctor. What do you think? Why are you asking me what I think? You give me a plan and I'll tell you if it works. It comes on to you, and you have to make those decisions. So that's the part that kind of makes you say, well, did I do the right thing? Am I doing enough? And residency has a way to kind of get you into that process. I'm still learning. There's a lot, I've just started my residency. I still feel many times that, oh, maybe I'm not doing this correctly. And You obviously reach out to your attending every time you have a question, but you can also look online. And not online, I mean like a Google search. I'm talking about like up to date. You follow these point of care medicine apps that can provide you with some sort of a outline of what to do, and they have some they have tables, they have outlines, they have information on what you should be looking for, what you can start with, can your step 1 can be, or your step 2s can be, and so you could use that information prior to presenting to your attending. So first day of my Bravo was kind of easy. The following week it got really tough. I got a lot of patients coming in. I had to start to see them, and then once I started to admit patients, right, admitting them from the emergency, that kind of took a completely different toll. Because if you are just taking a patient from another doctor, there's already a plan set. There's already a health care plan for this patient in motion. All you're doing is like the train is going, you just jumped on, and the one train, the operator was like, okay, I'm off now, continue with what we're doing, and you just continue with what the plan was. And if need be, you have a little deviation here or there, but that's basically it's easier part. But when you admit a patient, when you got a brand new patient from the emergency will tell you like 10 different things of what may have happened. And then you would have to ask a specific question, and which is something even I didn't know in the beginning. Like, you ask a specific question to the ER, be like, okay, but why are you trying to admit this patient? Right? What is it in your, what do you believe requires this patient's admission into the hospital for my care to take on the plan? And sometimes, the ER physician will tell you a lot of information and you don't know exactly what is the main reason for the admission. And so you can make it very clear and say, oh, but what is the main reason that at the moment that seems to be the problem? And they'll tell you like, oh, this person had a stroke, and now we're kind of working up with the stroke information, and we want to admit him and have an observation and get the further management done. You're like, okay, now I got it. Yes, the patient had hypertension. Yes, the patient had an infection. Yes, the patient had this. But this is what we're trying to start with. And obviously, those things you're going to take care of right after. So the admission part requires you to kind of hone in on your focus and try to figure out, well, why is this patient moving from the ER onto a bed in a floor in the hospital? And that is important because not every patient needs to be admitted. And you need to figure out that information, because one thing that you're going to learn as you go through your residency, and even now I'm still learning, I don't know, is that, the hospital keeps that information in check. Like, hey, this patient was in observation and 2 days is the limit for this patient. We didn't need this patient to be here for 5 days. Or, we got this patient and they were admitted for this problem, and this problem provides and pays for 4 days of admission, 4 days of being able to stay in the hospital. And, and we went 6 days. What was the reason for the extra 2 days? So that all information is kind of something you learn as you go through it. There are certain diagnoses that provide certain days in hospital, and there are certain diagnoses that don't. And you need to be able to know what is causing this patient to be admitted. So once that's just part of the, the tough part, where you have to figure out, well, what is the diagnosis that will get this patient the care that they need? And then after that, you have to, because you're the person who's taking on the patient, you have to be the one to make the full plan, right? You're the one who has to come up with like, okay, I do have a COPD exacerbation. Now, what am I going to do? What is my plan? What am I starting this patient on the floor? Or is this patient maybe going to go into surgery? Should I consult a surgeon? Should I consult a neuro? Because, he may not be, he's a little confused, and I think maybe we need to do an MRI and check in on that. Or maybe this person's kidneys are failing, and I think I should definitely speak with a nephrologist or kidney specialist. You need to figure out all those things, because now you're becoming the primary care team. And
Got it.
And you basically have to make sure that everything is checked on the list of this patient's care, from what fluids they need to be getting, if they are NPO or if they're not NPO and you think they need to be on fluids, what antibiotics, if this person has sepsis or maybe has a potential infection, you need to figure out where it could be. And then you have to also figure out the dispo, at what stage, what stage of the is this patient ready to be discharged? At what stage does this patient need to be at for me to transfer care to, let's say, a long-term facility at a home or a specialized nursing home facility? You need to understand what the nursing homes or different types of transfer of care after the hospital, what duties or things that they can perform, and then see if your patient is ready to meet those requirements and then can be transferred over. So those are that goes into your planning, and that should start from the admission date. So as soon as you get a patient, you start thinking about, well, this patient has come in for this. When do I want him to maybe move to the next point of care? This person has come in for COPD, or this person has come in for stroke. Maybe they need to go to a long-term facility because the stroke was extremely damaging. Where do I want them next? And you need to be able to make the call of who the specialist is going to be that you need to call. Let's say this patient has a nephrologist that is managing them, and unfortunately you call the nephrologist, they're not picking up. You're going to be like, okay, well, I'm going to call a different nephrologist because this is an emergency. And then you call another one, you bring them on. So you have to figure out, A, do they need a specialist? B, which specialist do I refer to? So
Gotcha.
all that information you have to do on admission can be a lot, and can obviously, it's a lot of work. You have to basically come up with a plan for a brand new patient that is sick.
Right.
So it can be extremely daunting. But obviously you've got help, you've got other individuals. So that's how my first week was. I had admissions after these patients. And again, because I was the only individual on my rotation, I didn't have a senior with me, right? I had to go to the inpatient adult service senior, because they're always on, to ask them, hey, give me a lay down of what I'm supposed to do with this individual. I had like this 17-year-old patient, and I was like, this patient's having like seizures, and on top of seizures, they're having weaknesses. What do I do? Like, I know by the book what I need to do, but what am I gonna do that may be better for this patient's care? These are the things that I want to do. And then your seniors do provide guidance and assistance. And matter of fact, which is the craziest part, on my third day of my rotation, like this is like July 3rd or July 4th, as soon as I came in, I had to transfer a patient from our hospital to a higher level of care for to New Orleans for to see a pediatric neurologist. And I had, so what happened is I had to call down, I had to call the transfer service in our hospital, the transfer service was like, okay, we're gonna call them and ask them what they want to do and what they're gonna do. And then they called the other hospital. They said, hey, we have a patient we want to transfer. They said that in an hour or so, I'm gonna have to jump on a group call with a group of pediatric neurologists and internists or hospitalists, and explain to them why my patient needs a higher level of care and what I have done up till now, and moving forward, what my plan would have been and where they come into play. And this is my third day into my residency, and I have to speak to a pediatric neurologist who most definitely has been through fellowships and years of training, and is a full, has a licensed, full board certified doctor, and not just one, multiple of them in that room with another internist. So it was such a scary call that I had to make. And then once I made the call, and I'm sitting like in the room where there are other seniors, so they can just like, if I need any help, they can jump in. We put it on speaker, and I was just talking the whole time. I explained what happened. I gave them step by step of what we did each hour with the patient. And by the end of it, they're like, fantastic. I think you're definitely right. We definitely believe that this patient needs that transfer, and we accept it. Now, sometimes they may say, hey, we don't accept it. I think the patient, you could continue managing this patient. I don't know why you need our help. But this time they were like, yes, we'll accept the patient. We have a pediatric neurologist. We'll take over from here. And then they were like, how do you want to transfer this patient? And I'm like, well, my patient is not, right now we kind of have them stabilized, but I don't know how long we can keep this stabilization because they're debilitated. So so they asked me, they're like, in that situation, what do you want? You want air or do you want by land? And I said, no, I think we need air. They're like, okay, do you have a helicopter or do you want us to send a helicopter? And then I'm like, I don't really know. I don't personally have a helicopter. And I'm like, and then
Not yet.
and then on our team, I was like, maybe you could do a Uber X. I don't know. And then on our team, our transfer team, they said, don't worry about it. We would like a helicopter. And then the hospital, they said, okay, fantastic. We're sending the helicopter in the hour. They were like, oh, we'll check the wind and everything, and we'll send over a helicopter, get the patient stabilized, ready. Please print out any of the documents that we may need in terms of further care, and please provide that with the patient, and then bring it over. As soon as that call ended, I had the biggest sigh of relief, and I turned around to my seniors, and then they just clapped, and they're like, we've never. They're like, in the 3 years, the senior was like, in the 3 years I've been here, I've never made that transfer call. And I am surprised that you were able to answer every one of their questions. You presented your patient, and you didn't stutter, and you spoke clearly. They were like, they were all very surprised. They were all surprised.
Awesome.
They're like, this seems like you've been at this for a long time. I'm like, I was scared. I was super scared because I needed them to have the right information, because there is a real patient that requires management. So, that was in the first week. So obviously, from there on, it was a lot like this. But yeah.
When you were when you were a med student, step one, when you got into med school, the idea that you had of being a physician, then you went into clinicals. I'm assuming that changed a little bit, what it would look like. And then finally, now that you're a resident, can you tell us how that idea changed about the kind of work that you had? Well, first of all, I mean, your example of the airlifting and the most challenging conversation that you had, that sounds very Grey's Anatomy, kind of. Like, that's kind of what, like, they would make an entire episode on Grey's Anatomy on. So that's really cool to hear. But as you went through education and residency, do you think that your vision of what doctors do has changed, and what you're getting back, is this everything that you were expecting?
Right. So I mean, when I first was, thinking about medical school and getting into medicine, I didn't think I would be that type of individual who could be like doctors, because I always thought doctors were extremely studious and individuals who are continuously studying, and they're like in the 99 percentile in terms of intelligence. And you have to be up to that point. I mean, nothing less than 100 would, throughout your life. You have to be absolutely perfect. And so what I learned throughout my journey is that that's not always the case. And majority of it is more and more so that determination and hard work kind of gets you to those points. And medicine is just like that. I mean, in terms of practicing, residency is exactly like that. You have to have the grit. You have to be able to push through the tough days and the pressure days, and be able to stay focused and clear, and knowing what you're supposed to do for the patient, for the care, and in terms of how you practice, that has to, that continuously evolves. And what I mean by that, and this is something we have to kind of understand, is, I always thought when I was looking into medicine, and then that change in rotations was, what a doctor does, right? I had this idea, like in my image, due to shows or TV or movies, that the doctor is a person that does everything, from a broken ankle to brain surgery. That doctor does everything, and they do it all. And then as you go through rotations, you figure out that each doctor has a role to play in what we call the care plan for the patient, and all of it needs a component, and each component is designated to each individual, right? So that is something that came slowly, or something that I learned during my rotations. Okay, your primary care doctor has, let's say, it's like your quarterback calling the shots on, okay, what we need to do here, what we need to do here, what we need to do here. But I need this individual to take care of this part, and I need this individual to take care of this part. And so each further component of that plan has a designation and specialty and something they focus on, and that plan gets further down the road. And so, my whole life was like, oh, I need to know everything. I need to know it all. And to some extent, that is true. As a primary care doctor, you need to know everything in every little field. But then comes a point where you know that, hey, I know up to this part, but I know based off my judgment and information that this is the point where the specialist needs to take on. You need to know that difference. Like,
Okay.
this is where the specialist needs to come in, and this is where they have to take care of the patient from here on for this aspect of this patient's plan. So again, my ideology changed when I started my clinical rotations. I started to learn and understand the teamwork that goes behind the care plan for each patient and every patient. And now moving forward, going into residency, now there's a little bit of tweak to that even further. Obviously, the plan, my understanding of the team, it's still here, and you continue to with that team. But now you have to learn about the legislation or the policies of the hospital, of the system, and how you can bill for the practices. What are the things that you can do, and what is something that the specialist can do that you cannot do, right? What are some things that you will need a specialist, or you need someone else to come on board? And as you go through it, you start to learn that in residency, you have to be able to learn these policies, because this becomes extremely important in your practice, right? Once you go, because up till now, one of the best things about it is that if I do make, let's say, or if I don't know, or if I make a mistake in the charting, I know someone like there's a team specifically for billing that will look out for me, or say, oh, you know what? You forgot to fill out this information. It's needed for this patient's further, the insurance to be able to be paid, or this or that. Those are things that I had to learn. Those are things I have to learn moving forward. And so once you're out of practice, you're on your own.
Right.
And that can provide, that can be daunting and scary. So what I'm learning is, and this is the craziest part, you could be a doctor that just focuses on primary care, take care of your patients, and hire someone to do the business aspect. Or you could be the doctor who can learn these different things and be able to become your own. You can make your own practice. You can make your own billing. So you can do your own. You can hire your own staff and go and pay according to your own staff. So there are different avenues you could take, and obviously you have to learn all those things. Now, prior to that, I didn't know any of this. To me, billing and all this extra information on policies and how long can a patient stay in the hospital, or what that, you don't think about those things. You think about medicine, you just think about maybe Grey's Anatomy or this or that, but you don't actually think about all the extra stuff that goes into the actual care, right? And you also have to start to consider, why am I ordering these things for this patient? If you watch, I'll give you a great example. House is one of the shows that I always loved, and you go back and you watch House. He orders like the most random, most bizarre labs in the world. And those labs probably cost a lot to his hospital. And at the end of the day, they may not provide any extra information for him, right? So each time you order a lab or you order something, they ask you, like, what do you want? What are you trying to see in this lab? Or what are you trying to see in this imaging? What is it that you want from it? Don't just say, I want a chest x-ray. What do you want the chest x-ray for? You have to be able to tell them what you're looking for based off of your clinical judgment, and what do you want in terms of the lab or imaging to confirm your diagnosis, or at least point you to the right direction. So all that stuff you need to kind of learn, and you got to pick up on. And I thought, I could just order, like, I have this patient, give him a full CT. I want to see what's going on with the whole body.
Right.
That's a lot of radiation. Why do you want a full CT? there's something you're looking for. Oh, I don't know what's going on with the patient. Well, you better figure it out before you order some random expensive, lab. So
I see.
That's what changed for me.
Okay. So basically, like, it seems like when you're in residency, everything's a little more purposeful, whereas in rotations, you're just learning and you get a lot of information. But here, it's like you have to process the information that you picked up, and then now you need to know why you learned all that in rotation.
Exactly. You got to figure it out. I mean, you can't just be and the best thing about rotations are that, you're not making any judgment calls. Your preceptor may ask you like, hey, what do you think we should do here? What do you think? But at the end of the day, they're the ones that are making the calls. You're not actually going in to put in the orders. You're not the one who's going to put in the information. So that's where you have to that's the difference in residency. You got to actually understand why you're doing what you're doing. Right.
That's interesting. So now, as far as difficulty is concerned, on a scale of 1 to 10, where would you rate basic sciences on a scale of 1 to 10? 10 being the most difficult.
10 being the most difficult. So I would probably rank basic sciences at a 9. And the reason why I would rank it, I might even put it at like 10. And the reason why I would put it almost close to 10 is because there is a lot of knowledge and information in basic science. There's a lot of information, right? They don't care if you're being a surgeon or if you're going to be a pediatrician. They're trying to train you for medicine, and there's a lot of knowledge that goes into it. So basic science, the reason why I rank it at 9 is because of there's abundance of knowledge and there's limited time. So you got to put a lot in a lot less.
Got it. What about clinicals?
Clinicals, I'll put it like around maybe 7. The reason, because when you get to the clinical point, your basic foundation is there. You've honed in a lot of information. You've completed your steps, so you kind of understand the rhythm of things. Yes, the difference is that some preceptors may be very kind to you and they may not pimp you as often, and others may be extremely tough on you. But at the end of the day, rotations. What
do you mean by they may not pimp you? Is that what?
Yeah, pimping is what you call like when your preceptor or your attending asks you questions in front of, let's say, a patient.
Okay. It's called
and
pimping.
I don't know what exactly. Maybe there's a reason, but to my understanding, pimping is like, I've got this new person, the student, and I'm going to ask them questions. I'm going to test their knowledge on the spot.
Gotcha.
So pimping is tradition in medicine, and it happens a lot. And preceptors love to do it. Attendings love to do it. And where they ask you questions, like in front of the patient.
I got
and you may come up saying, "Oh, I don't know."
All right.
And then they'll drill that information in front of everybody in interview. So.
And what about your residency? Where would you rate that on a scale of 1 to 10? On the same scale, which also includes work hours, responsibility, and all of that. So
it'll probably easily sit at the 9 and 10, right? That's where residency will sit. The hours are, they can be extremely, there's a lot of hours. That's just the truth of it.
Right.
There's no going around the hour part, but there is time for you to be able to do the things that you enjoy, and for you to be able to kind of have your hobbies and whatnot. So there's definitely room for that. And the other aspect about residency is just like basic science, right? There's a lot of hours and a lot of information in even with all these hours, a short amount of time. Right. Because now you've learned, what the care for a patient is in terms of a chronic disease. But when do you know you need to switch up or switch down or change, or what medication to start with, or what dosage to start? Or what are you looking for when you start the medication, right? Yeah, you may have learned it through your rotations. You may have learned it through the readings of your books. But in practice, it can be very different, right? You got to also look at the socioeconomics of your patients, right? Like this patient just had a heart attack. They need to be on these medications. Can they afford a $300 medication that they have to take every day?
Right.
You got to start thinking about those things.
Right. So one of the things that I would like to point out to you, Dr. Hanan, is that essentially medicine is obviously an extremely high-powered career.
Mm-hmm.
Any other high-powered career, and I don't know that this will make you feel any better about your long hours. Not that you're not feeling good about it, but I'm just saying almost any high-powered career that has a very high earning potential, like a physician, they all have very, very long hours. Whether you talk about investment banking, whether you talk about consulting, or whether even if you're talking about general entrepreneurship, if someone's trying to build a company or general IT, these guys are working 60 hours plus. That's your standard work week. And I think that's what I think medicine does, is that they make you, say, for example, if you're an IT consultant and you want to start your own business or you want to get into Google, you're putting in those crazy hours. There's no question about that. The only difference is that with you guys, with physicians, it seems a lot more structured. So you're all going through it's trial by fire for all of you. Whereas in a place like, as an IT consultant or a finance major, they get the choice that, hey, are you willing to put in 60 plus hours to get this high powered career? Or are you going to say, I'm going to be a clock watcher, work 30 hours a week, and then I value my personal time, yada, yada,
Right.
yada. And then that's a clear choice. But at that point, your earning potential is just not that high. It's
Right.
as simple as
And
that.
to that point, which I love with that you spoke about, like hours in different fields and everything, and that's extremely true. You know, any position that you want to do, whereas like say a specialized field within that field, or specialized position in a certain field, be it medicine, be it law, be it business, it requires a lot of hours of work. And that's what I said when I was talking about in the beginning, that in order, when you go through it, you need to have grit. You need to be able to handle the hours. You need to be able to handle the stress. And, those hours and that, that schedule can be extremely daunting and can put you down, or it can actually uplift you if you enjoy it. So in my case, the hours, I have heavy hours in my week to week, but I don't mind it. And actually, it doesn't really bother me. I enjoy it. I like to stay at the hospital. I enjoy what I do. It's learning for me. I enjoy that aspect of medicine. When I have to see my patients, and the best part about it is, because I get to see my patients, I get to take care of my patients. I get to see how they progress from a position where they first met me, where they may be in a horrible situation, to then months or weeks after, where they're a lot better and a lot different, and then now they're going through the day to day with a quality of life. So those are things that you actually, if you're in medicine, those are things you want and those are things you enjoy. So the hours, as crazy as they can be, if you enjoy it, I promise you, you'll never notice it. Yes, you may get tired. Yes, you may need to take a random nap in the middle of the day. You may become exhausted, but you won't go to the point like, oh, I wish I never done this. You'd never say that. Some people would say like, oh, when they go into medicine, they'd be like, when they got into residency or the thing, they're like, oh, if I could see my younger self, I'd be like, don't do this, go into a different career. I don't understand those people. I don't get it. Your whole life, you worked to this point to get to be able to manage and help patients. This is what you wanted your whole life. Now you finally are able to do it.
Right.
Isn't that fulfilling? And that is fulfilling for some, and for myself, it definitely is. So that is why, the hours, as crazy as they can be, if this is something you truly enjoy, you'll love it.
That's awesome.
And hours will not matter to you. And just one more thing off that exact point, there are doctors, again, once you finish a residency, you, just like any other field, you can manage it however you please and wish. You can do 7 days a week, or you could do 5 days a week, or you could do week on, week off. And I've seen some doctors do week on and week off. And I've seen some doctors say that if my patient calls me in the middle of the night, I'll pick up that phone. And some doctors say, well, I won't pick it up, but I'll have some other thing in place for them to just, so it all depends how you want your life and how you want your hours. So You could do as much as you want or as little as you want. It's all up to
That's
you.
amazing. Well, I'm sure hoping Canada doesn't take you back. I hope you stay in the US.
Now, when
Because
we get to that point, I'm gonna
you
figure
have
that
the
out.
makings of a great doctor, that's for sure.
Well,
I mean, we
thank you.
knew it even while you were in school, so that's not thing. So my last question for you is, you got into a residency program. That's a pretty large residency program. It's a part of the university. So by no means were you a stranger. You had other St. James students there in other years. Does having that really matter? Does it matter that you had scores of St. James students match in LSU before? Did that matter to you at all? Not while applying, but now that you're actually starting the program, does that matter to you? I know during the application process, I know you reached out to a lot of alumni who are working in LSU, and they kind of held your hand a little bit in the beginning during the application process. But now that you started, once you moved there, does it matter? Because I get this question a lot from a lot of our viewers, a lot of our students. They're like, none of St. James graduates have ever matched there before. I kind of don't want to go there because there are no SJSM students. Does that matter at all? Like, to you, are you meeting your alumni? Are you guys sitting at the lunch table together and just, forming a little clique that's from SJSM? Or does that affect you at all?
It doesn't matter. Be honest with you, it doesn't matter. I mean, I'm glad I have a friend. I'm glad I have like a individual in this program that I knew prior to getting into the program. And doesn't matter what school you're from? Absolutely not. I mean, you wouldn't even know the person who's sitting beside you or across from you when you're taking care of patients or in the room, what school they went to, because it doesn't really matter. It actually, and it doesn't matter what scores they may have had or got. It doesn't matter, how many years they may have taken to go through their residence, their medical school. It doesn't. All those things don't matter. What matters is, can this person be someone I can rely on while I'm working with them for like 24 hours? And that's all that matters. That person needs to be a mentally sane individual that can handle pressure and not offload that pressure to you, or cause extra issue for you, that because they're having a breakdown in the middle of like a stressful situation. We just got a cold call on one of our patients. We got to be there bedside. Maybe this person needs a central line and needs to be intubated, and this person's freaking out in the corner like, I can't deal with that and deal with this at the same time. And there's one of our other ICU patients starting to code, and now I'm like, hey, listen, we need to, you need to focus. You need to get that. I need to get this. We need to kind of be oriented. So it doesn't really matter where they're from. It doesn't matter what school they're coming from. All that matters is, can they perform in residency with a clear mind, and can they get through the hardships with you side by side? So I've been very fortunate that my fellow residents have been fantastic. They've been great. We were able to work well together. We're able to get into the zone together. Now, like I said, I think in the beginning, or maybe I'm not quite sure, I was just speaking before, I don't even know what schools they're from. I should, we've become somewhat of close friends with some of my residents. I mean, those are some things I could ask, but more often than not, we don't really ask about school. We just ask about how your experience has been, what you've been through. So if any student is out there saying, oh, my alumni is not in this program, I don't want to pick this program because of that reason, that's a horrible reason to not pick a program. Be real with yourself. What do you want in a program? What is it, something that you need? Do you want a program that is unopposed? There's no other residencies going on. Do you want a program that's community based, or is it a community hospital? Do you want a university hospital? Make your decisions of where you want to go in residency based off the values that you hold and where the trajectory of your career needs to end up. Not based off of, oh, there's no alumni there, I don't want to go there. No, that's not. If someone told me that was a reason to not pick a program, then that person is definitely not a good candidate in the first place. Because they're worried about things that they shouldn't be, that are not something to be worried about.
Right. Well, but thank you so much, Dr. Hanan. I really appreciate all the insight and views. This is the first time we're really talking about life as a first-year resident. We have always skimmed at it at a high level. You've given us a lot of valuable insight as to what like your third day was. I'm really stressed about that phone call. But thank you so much. This is going to be so helpful for students. And again, as always, we always appreciate you. We always appreciate the time, especially now that your time is a lot more valuable than it was before, because before you were here, so we would just grab you and make you do stuff. Now we can't really make you do stuff.
Thank you so much for tuning into our show. We hope you enjoyed another episode of Med School Minutes. If you like our content, please follow us and receive notification when a new show is posted. This podcast is brought to you by St. James School of Medicine. For a video version of this podcast, please check us out on sjsm.org/video.